So let me start. You know, if you think about it, we all have had, and you will have too, a long and hopefully meaningful journey. And I can't help but say that I go all over the world giving talks. And I was recently in Germany, and I started reflecting on how young this country is. This is a relatively young country, particularly when you consider that we're the wealthiest nation of all time, even if you compare us to the Roman Empire and British Empire. We still have the greatest military strength, irrespective of who you might talk to. We still have the best technology of any nation. We have the most research and funding. And I didn't know this. I thought Germany had the most Nobel laureates, but we actually had the most Nobel laureates in this country. And up until the 8-hour work week, we used to have the best graduate medical education. I'm not sure about that. But what has been a question mark has been our healthcare system. Now think about it, and Dr. Brockman alluded to this. We're the wealthiest nation of all time. We have a $2 trillion industry as far as healthcare. There's no other $1 trillion industry in America, not agriculture, not business. The only $1 trillion industry is healthcare. And we have a third of our population either uninsured or underinsured. In fact, if you look at this slide, and I know it's busy, but 1 is the best number you can have, and 6 is the lowest number you can have. For the United States, that's US, and other countries they're comparing us to are Australia, Canada, Germany, New Zealand, UK, all places I've been. You notice that we're 6 a lot. And we're particularly 6 when it comes to equity. In other words, we have the best healthcare system, make no mistake about it, but only for a small cohort of patients. And that's why I wanted to come here today, because we have an access problem. We have a lot of challenges, and I'm particularly pleased because I can see some young minds in the audience that will likely help us with some of these challenges. As you see here, the uninsured, the technological revolution, all the things, aging population. But what I would like to start with is the workforce shortages. That's one of the reasons why I'm coming, because this is the potential pipeline into healthcare. We have a major shortage in all specialties, but I'll talk about mine. We have a major shortage in general surgery. And a lot of people don't realize when you don't have a general surgeon in a community hospital, that hospital will soon close. And when the hospital closes, it impacts the whole economy of that particular community. And so I had to look and assess what sort of inventory do we have. Well, we don't have a robust number of people in the pre-med pipeline, and that's why I wanted to come here, because I know you all are mostly pre-med and pre-public health. We certainly don't have the numbers that we need in the undergraduate medical education, i.e. medical school pipeline, and we don't have that many people doing residencies. In fact, if you look at the allopathic graduation trend, it's been pretty much static. So we're not doing much, although some schools are trying to increase, but that's negligible if you look at the overall need. And even if you add the osteopathic infusion of healthcare providers, they only add another maybe 2,000 or 3,000. Now, here's some facts. We've had very few new medical schools over the last quarter century. We have doctors like myself older than 55, not much older, but older than 55. We have medical graduates who are women, 50%, and why am I saying that? Because there's some specialties that have not been, how can I put it, supportive of women in their training programs, like surgery. So we have done a poor job. And you have, obviously, a population of patients who are getting older. And then we have some other facts. We have a shortage that's expected to be, by 2020, 200,000. And we have, obviously, a quarter percent of the doctors in U.S. residencies are foreign. And the reason why I wanted to bring this up, because there are some people that are confused. They're saying that maybe we should cut the market of international medical graduates. That would be a mistake of biblical proportion. Let me tell you why. Each year, we need an infusion of 22,000 physicians each year. Boots on the ground. We need doctors, 22,000 every year. Well, think about it. Let's do the math. We only have 16,000 finishing medical schools. And then you want to add another 1 or 2 from osteopathic schools. If we didn't have that 7,000 that you see at the bottom of foreign medical graduates, oftentimes they're the cream of the crop, we would have a major shortage, even more major than what we have now. So people are confused when they talk about closing the border to international medical graduates. I think that would be a mistake. And particularly if you consider that this population grows 25 million every 10 years. So it's growing and it's getting older. Now here are some of the imperatives of the AMSA. They're saying that we need 10,000 more doctors by 2020. Number one, they're not going to get that. And number two, that's too low of a number. We need 60 new medical schools. Well, number two, they're not going to get that. And we need a 20% increase in existing schools. Most schools can't afford to expand that much. They don't have the infrastructure. They don't have the faculty support for that. They might want the money that 20% increase will get, but they don't have the true infrastructure. Most schools don't. So in all fairness, one of the things that medical schools have to consider, all healthcare organizations, is increasing the racial, ethnic, and geographic diversity. And that is probably the true mission of this meeting. In fact, a lot of people like to talk about diversity. I see a very diverse audience. A lot of people say, oh, it's very charitable. But let me just say this. Dr. Bourne and Dr. Bach, and you might have not have heard of those authors, but let me try to make it relevant to you. Dr. Bach was president of Harvard University. Dr. Bourne was president of Princeton University. They wrote a very classic book called Shape of the River, talking about the need to have diversity, that American society needs to have high-achieving minorities, not because it's charitable. The business world has already discovered this. You need diversity not because it's the right action, but it's the smart action to take. You're not going to be successful in any initiative if you don't have a diverse group. There have been organizations that have been proposing this for years, but now it's become a little more global. People realize that if you don't have a diverse pipeline of providers, there's no way you're going to address the increasing diversity of the population. Here you have the NMA, the National Medical Association, and the Society of Black Academic Surgeons, but there are others. And even the Institute of Medicine, our premier organization, did a study, and they realized that when you talk about the 6 aims of care and providing optimal care, it has to be safe, it has to be effective, it has to be patient-oriented, timely, efficient, but it also has to be equitable. And that's what we don't have. In fact, they made the study, and they came up with the conclusion that you're not going to be able to address disadvantaged areas if you don't have a diverse workforce, healthcare providers. Because those healthcare providers from a diverse background often go back to those diverse communities. Now, we have a lot of technology, as I stated. We have the greatest technology of any country, in fact, too much. I'll go to Philadelphia, and in a one-mile radius, every hospital has robotics and transplant programs. I'm not sure we need to have that sort of a comprehensive assessment. But at the end of the day, the great paradox is, what good is scientific discovery of all that technology if it does not apply to all who need it? And that's the case. I like showing this woman. It's very unfortunate. You would think that somebody now, you're not in medicine. Some of you all are not in medical school yet, or public health. But you don't have to be a healthcare provider to see that this lady has advanced cancer. She has advanced breast cancer. She died within 12 months of this photo. And she was not from some sort of underdeveloped country. She was from the United States. She was an access problem. She didn't have insurance. She didn't have any way of having her health monitored. And by the time she presented with advanced disease. That's an access problem. And that's an access problem in the wealthiest nation of all time. Had she been seen earlier, there's a good chance she would have been obviously operated on, maybe adjuvant therapy, and probably would have been a cure. So, what message am I bringing you? I'm telling you that in the wealthiest nation of all time, we have a paradox. We have a $2 trillion healthcare industry, centers of excellence, translational research, unbelievable growth of infrastructure. But on the other side of this slide, you see we have decreased access to healthcare. We have increased mistakes being made, even in some of the established centers. In fact, any ICU, probably with the exception of UC Davis, because you all do everything perfect here. Any ICU in the country, they make 1.2 mistakes per patient per day in this country. You have suboptimal preventive care, all the things that you see here. And so I have to ask myself, and you will have to do the same, particularly if you're going into public health. If we're spending all this money, why is it that if you look at this slide, and this is not my slide that I created, this is data from the Robert Wood Johnson Foundation, one of the premier organizations for looking at factual problems. Now, what they're saying is our lives are shorter by almost a half a decade if you base it on how much we're spending. So we're not even getting our dollars worth as far as health care benefits. This is what we should be going for, and hopefully this is the goal of the audience. We should have a bell-shaped curve, meaning that most people get the best health care. Instead, for those who know statistics, it's shifted to the right, meaning that there's a small cohort of patients that get the best health care. Most people don't. In fact, Dr. King made this comment to a cadre of healthcare providers. He had some healthcare providers there just in case somebody got sick or beat up from the Selma to Montgomery march. To that cadre of healthcare providers, this is what he told them. He said, you know, of all the forms of inequality, injustice in health is the most shocking and the most inhumane. He was talking about access. In fact, in 1955, a couple of years after I was born, the greatest health risk was acquired heart disease. Now in 2010, the greatest health risk by far is lack of access to care. In fact, I believe this. I think for this century, the new era of civil rights is healthcare inequalities and disparities. Let me give you an example. I know we have some wealthy people in the audience. If you're in the high income bracket as compared to the lower income bracket, you can expect to live 6.5 years longer than poor men and poor women. And if you're in the lower income bracket, if you're a poor adult, and I know there's probably no one poor in this audience, you are nearly 5 times as likely to be in poor or fair health. And if you're a child from a poor family, let's say you're a child from a poor family, you're 7 times as likely to be in poor health. Now, those are disparity problems. And I'm not even talking about the racial and ethnic differences that you add on top of that. And I'm not even talking about the geography. If you are in rural America, for those who don't know rural America, Sacramento is not rural America. It might seem rural, but it's not rural America. Most people live in rural America. Rural residents have less than half the access to specialty care as compared to somebody living in an urban setting. So I've just told you what healthcare disparities are all about: geography, ethnicity, racial, income. By the way, in the wealthiest nation of all time. Let's look at this slide. This is a great slide. If you live in Phillips County, Arkansas, if you can see it, that's right in the middle, as compared to living in the greater Washington area, just because you live in Arkansas, your lifespan is 10 years less. That's from the beginning. Now, think about it. There's no way that we can sit on the sidelines and support this and not do something about this. In fact, I gave this in my presidential address. This is the only slide I'll show you what I talked about. If you want to find out about my presidential address, you can always Google it and it'll come up. I think we need to provide this sort of leadership, because I got to tell you, this is one of the few times, I'll say this now, that more money will not solve this problem. 7 years ago, we were spending $1 trillion for health care. Now we're spending $2.2 trillion. 5 years from now, we'll be up to probably $3.1 trillion. You can throw all the money, but money will not solve this. It's going to require different leadership. It's going to require us looking at how to prioritize management and not waste money, not have a CEO of a 5-hospital consortium making $3.7 million and can't even spell on call. We're going to have ways of obviously modifying how we're doing health care. And we need to emphasize what's best for the individual patient and what is best for the population. In fact, if you look at it, there are only 2 fundamental variables that impact health status. That's 2. Quality and access. And I go all over the country, they always like to point fingers at the United States because they know the dilemma we're in. But I can tell you right now, there is no other country with better quality than the United States. The problem we have is with access. In fact, I look at access like this. Patient care is a 3-legged stool. One leg is quality, one leg is safety, and one leg is access. That stool will not stand up if you break one leg and the access leg is broken. In fact, I've said this and I'll say it here. There is no quality. Let me repeat it. I don't care how fancy, you can call it a quaternary hospital or a tertiary hospital. No, there is no quality without access. I'll specifically talk about surgery. We've had a precipitous decline in general surgeons. In fact, unless there's green on here, you don't have the right number of surgeons. And you don't see a lot of green on this slide. And this is just a bar gram of showing you how we have dropped even in my specialty. Now, why is that important? Let me tell you why it's important. There are only a little over 3,000 counties in the United States. 3,000 counties in the United States. You know how many counties you all have in this state. Although I know this state is bankrupt, you still have counties. You have 1,168 counties that don't have a surgeon. Now, if you understand this, the premise is this. If you don't have a surgeon, that means that if you get sick with an acute illness, that's like this young man who was on the plane. He was 50 years old. He was young to me. He had left lower quadrant pain with localized peritonitis. I knew what he had. He had diverticulitis. And I told the pilot that he needed to, we were only 10 minutes removed from landing here in Sacramento, that he needed to be admitted to the hospital and worked up, and if he did not recover, he would need surgery. Now, that was an acute emergency. Let's say he was in one of these counties without a surgeon. He would be in trouble. because that particular problem needed a general surgeon. That's like a perforated appendix. So think about it. I know you said, well, that's not going to bother me. I live in Sacramento, and I eat sunflower seeds, and I enjoy myself and all of that. But let's say you're driving across the country, and let's say you get sick, and you happen to drive in one of these areas. In fact, the next slide shows that you have still another 360 counties that have one surgeon, still less than what they need to have. So half of all the counties in the United States don't have a general surgeon. Let's say you're driving, and you come to one of those counties, and you have a perforated ulcer, then you have an access problem, and there's a chance you're going to have a bad outcome. Now, we also have this challenge, and that's why we need more people in this audience to pursue health care. We have a population that's aging. I hope I'm on that curve where I'm going to live to be over 100. But you have to remember this. For my specialty, an elderly patient requires twice, if not 3 times, the time and effort of a general surgeon. And you know why? Because as you get older, you have comorbidities. That means you have problems with cardiovascular disease and kidney disease and lung disease. So it makes taking care of somebody elderly more complex. Also, we have problems with not having the right people in our specialties. We've done a terrible job of recruiting women in surgery. That's why I see some women in the audience. I hope you all will pursue surgery. But right now, we have a problem because we have less than 20% of the resident pool are women. And we've done a poor job with minorities. This is an article I did with Dr. Paris Butler. He's a resident now at the University of Virginia, did some research at Stanford. And what we showed that at every level, there was a decrease in minority representation. Now, you got to have people, obviously, on faculty and professors if you want to have role models for people who pursue careers in medicine. And I don't need to tell this audience this. It's well documented. That's like I talked about. It's well documented that you have differences between minorities with colon rectal disease and early lung disease and all the like. But let me give you some facts. Minorities, now I could have 20 slides like this. I decided just to have one slide. Minorities are waiting for lung transplants, more likely to die. Minorities more likely to die from severe sepsis. Blacks and Hispanics are less likely to get strong pain drugs in emergency rooms. These are all documentation. It's not me. I'm not going through some sort of hyperbole. Minorities in poor areas are less likely to be on kidney transplant lists. Blood pressure control is less likely to be optimal with minorities. Prostate cancer, Dr. Brockman, more likely to return in blacks than whites. Well, at the end of the day, some people say that we have a profession that has become a failing industry. I don't like to call the healthcare profession an industry, but I do know we're in trouble. And maybe we started down this road of being in trouble when we shifted our emphasis in healthcare from educating physicians and healthcare providers and acquisition of new knowledge to putting an emphasis on profit and market share. I remember when we started doing that, I knew that was a mistake. Because let me just say this. I had a chance to have dinner a few years ago with Michael Bloomberg. Now, Michael Bloomberg, as you know, is the mayor of New York City, probably the most successful businessman. And I asked him, I said, Mr. Bloomberg, I noticed that obviously more business people are into healthcare now. I said, what is the mantra of the business person? What is your theme? He didn't hesitate. He said, LD, in business, there is no mission without a margin. Meaning there is no mission, there's no initiative they're going to do without some idea of a profit. Well, you can't have that in healthcare because there's a clash of values. You can't talk about the profit You're not going to get a profit in taking care of indigent patients. So this business model that people are talking about, this is a failed plan. Don't get me wrong, you still have to be medical executives and all of that, and you have fiduciary responsibility, but you cannot apply the business model completely in medicine. We have some difficult times ahead. Got a lot of challenges, all the things that you see coming up on this slide. But let me tell you about unemployment. I'm the most worried about unemployment because I know this state is very poor now. For each percentage point increase in unemployment, you have another 1 million Americans uninsured. Now, the impact is this, and I'll wind up. I don't want to go over my time. You have a public there that's frightened to death. Our public is frightened. In fact, they'd rather go to a magazine to find out what's the safe hospital, what's the best doctor. And they hear about how hazardous health care is. In fact, if you look at this slide, if you bungee jump 100 times, you have 1 chance in 100 of dying from bungee jumping. Mountain climbing, you have 1 chance in 300 that you might die. And in health care, for every 500 encounters with a hospital, you have 1 chance of having a fatal outcome. That's why you have a public that's very concerned. They're concerned because they know that we are making mistakes, resulting in death, as you see on this slide. 98,000 deaths per year. I think that's a little high, but certainly it's high enough that you should be concerned. And think about it. Americans receive about half of the recommended medical care. So there's a disconnect somewhere. We need not only physicians, but we need people in public health. There's a disconnect when you have half of Americans receiving optimal care. And we got a public man that does not trust us. I guess, why don't they trust us? You talk about, obviously, like what Dr. Brockman said about Virchow, that we're the natural advocate for the poor. They do not trust us, and there's some background for that. They know about the Tuskegee study, syphilis study. They know about the recent one that was just unveiled, and how the Willowbrook study gave live viruses, hepatitis viruses, to retarded children. They know about what we do. And so I can understand why they're frightened. These are small, relatively small, but still these are real facts. So in all fairness, let me start ending. There are 4 major forces influencing healthcare. The one that I'm the most embarrassed about is this one, information technology. I know we have some IT here. Healthcare has been relatively untouched by IT. That's one of the ways you can help access having a better IT system. Let me give you an example of what I mean. The last century, knowledge doubled every decade. They're saying in this century, it'll triple every decade. There's no way, I don't care how bright you are in the audience, that you'll be able to access, process, and implement that sort of information without IT. Everybody talks about Six Sigma. Six Sigma is relevant in the business arena. If you do FedEx, FedEx has 1 million transactions per day. They make less than 4 mistakes per day. We make 2 mistakes per patient per ICU. So there's no way we're going to hit Six Sigma unless we have IT. And this is a long list, but these are the things you can do with information technology. So hopefully there's some bright minds in here that can help us marry the two together, because we don't have that now. Look at electronic medical record. That's one component of IT. And look how far behind we are. We're to your right, United States. Because you're not going to be able to assess performance without some sort of IT system. So I'll go back to this 3-legged stool. There's an access problem, and the only way we're going to be able to address this in a multifaceted way. And that's why I decided to fly overnight to come here, because I know you're dedicated to addressing healthcare disparities. I wouldn't have come. I mean, I had 9 days in Washington. I flew in yesterday. Dr. Driggers picked me up, and I'm flying back in another hour. But I need to have some people that can address these disparities, because I look at this like we're going through another renaissance. There was one major renaissance from the 14th century through the 17th century. Our country was founded during that Renaissance period. I think we're in the Renaissance period now for healthcare. I hope it doesn't take centuries to resolve some of these issues. And why am I here? Because Sir William Osler, Dr. Brockman, said this: if you take the sum of human achievement in action and in science and in art, the effective and moving and vitalizing work is done between the ages of 25 and 40. So the sun has already set on me. If we're going to have somebody making an impact, it's going to be people your age. And so I'll say this as I close. Your leadership role cannot be delegated. If you're going into the healthcare profession, you're going to have to be a leader. Either you're going to exercise it or you're going to advocate it. And so in all fairness, the cornerstone of an enriched environment is going to be diversity, and that's the mission of this organization. Let me end with this. The reason why it's so important, and I'll stop. If you look at why people die prematurely, you don't want to die at the age of 30 or 40. You want to live to 80 or 90. The reason why people die, think about it, on this slide, health care is only 10% of all the reasons why people die prematurely. So this is a relatively small problem compared to other things that we need to address. That's why, in addition to being a healthcare provider, a physician, we also need people in public health. Well, I can go on, but I'm going to stop and thank you all for, and I'll leave you with this quote by Martin Luther King: life's most persistent and urgent question, and I want you to ask yourself this every day: what are you doing for others? Thank you very much.